Welcome to your ERT session. My name is Brad Fraser. I've taught a lot for SOS Technologies here. I teach for them and work for them for the last probably 20 years going on. I'm also a paramedic with BC Ambulance and instructor, and I love to teach and bring some knowledge and hopefully some comfort to you. The idea of today's session is to show you the oxygen units that are in your first aid rooms at your company, just to take a little stigma and maybe some fear out of it and how simple it is to use. SOS also provides A.E.Ds and lots of first aid supplies and kits that you can put into your company. So the idea is first aid training as well as first aid knowledge. A little knowledge in this area actually saves lives, and you could do some easy and great things to help your first aider at work and take some of this knowledge back home too and use it at home. How I like to start is just introducing the actual oxygen unit. This is one of the units that will be in your first aid room at work, and it is simply an oxygen unit in a kit. It's made this way so if it accidentally fell over, it would still be safe. There would be no danger behind it. Not a lot of fancy knowledge going into this in terms of all you would do is take out the mask, make sure it's on, and simply hit the switch, out comes the oxygen. This is called an inhalator, so your patient has to be breathing to use it in this form. And then turning it off is simply by returning the lever the other way, and it turns off your unit. That's how simple it is to use. You could be doing this for your people at work, your coworkers, or getting it for your first aider and helping them with it. These are always serviced by SOS. If it ever runs out, they'll come and replace your tank for you. So it's very good that way. Simply put, you just put it back in, they'll get a new mask, and off you go. Okay? So that's the unit. There's also an A.E.D, which you've all heard about, which we'll talk a little bit about later. And the unit comes in different forms. So this is called a soft pack. So it's the same unit inside, same lever, and it's an easy carry case. It also comes in this unit here, which is a hard pack again, which is the green plastic one. And that one's quite easy too. On lever, off, and off you go. You just help bring this out to the accident, the emergency at work, and you and your first aider can take care of the person with it. Just thinking about this unit then, what kind of reasons, why do you think you might need to use oxygen at work for a coworker? What kind of things could have happened? Heart attack, big one, right? Heart pumps the blood, blood needs the oxygen. So if the person who's having a heart attack, okay, chest pain, pretty classical symptom, the person is still alive, right? They're not at this stage. Heart attack meaning they need oxygen, they need anything to help perfuse, right? So what kinds of things could we do for that person with a heart attack? What's the first aider going to want to do, or what do you think you can do for that person?
Call 911.
Call 911 is huge. What we have, a little saying is time is muscle and time is brain. The quicker we can get 911 accessed and the paramedics there to your scene, the better results we can have, okay? So if the person had a heart attack, number one thing you do, call 911, put the person at rest, sit them down, lie them down, whatever really position they want to be in, go get the first aid supplies, and actually put oxygen on them. Simply as that, right? The heart is there's something going on with the heart, there's an arrhythmia, there's a blockage, and what it means is it's having a hard time to get the blood around. Therefore, the oxygen around to the different cells, especially the heart. Okay, so that's one. That's the big classic. Why else could someone need oxygen?
Asthma?
Asthma is huge. Okay, so asthma is a precondition that one of your coworkers might have, and they would normally have that puffer, salbutamol, Ventolin, or one of these puffers. And again, if it's an attack, oxygen can help. The thing with asthma is they're having generally more problems pushing the air out. However, supplemental oxygen can help them out as well, right? We can assist them by finding or helping go get their medicine, and we can give it to them that way. So those are some simple reasons why oxygen. We're going to go through a couple more. In terms of maybe some first aid knowledge in terms of how we would teach first aid or give first aid is literally simply the alphabet. And this is how first aid starts, this is how paramedicine starts, this is how doctor starts. It's about ABCs. And if you've heard those terms before, it stands for, anyone know A? Airway, breathing, circulation. And then all the permutations that can happen in an emergency or just in an illness. So A for airway, and when we think of ABCs, our primary motive in thinking about ABCs is life threat. So what's something life-threatening that could be in an airway problem? What could be going on? Choking. So it's called foreign body. Choking. So typically laughing, talking, singing, whatever, and then something goes down the wrong tube, right? We have two big tubes, the esophagus and the trachea. Normally everything's supposed to go through the esophagus. This one gets cut up and blocked somewhere in the epiglottis, larynx, trachea, the airway portion. And then we get that choking feeling, okay? So there's an airway problem. What other kind of airway problems could you have? Some of you might have it in terms of allergies, okay? Anaphylaxis. Okay, one of the main problems with anaphylaxis is it swells and shuts down your airway. It also drops your blood pressure. So most anaphylactic patients not only will have an airway problem, but eventually they'll have a blood pressure problem and be passed out on the floor, right? Blood's from the brain, down they go. Okay, so we can assist that person with, what do they usually have if they're anaphylactic? EpiPen, epinephrine, right? We can help them find it and they can take their EpiPen. What other kind of airway problems? Think of, simply put, you can always have some trauma. So it's a fall, and they hit their throat, they hit their neck, and then we can have a bit of an airway problem. What that means, though, is once the first aider's there and the treatment's begun, oxygen is your huge supplement for that treatment, right? Assisted oxygen. And it's an inhalator. As long as they're breathing, they can get it. So the next letter, B. B stands for breathing. What kind of breathing emergencies can we have? Why would someone have a breathing emergency? We already said heart attack. So that starts with the chest in terms of the heart. But what will happen is everything compensates. So now we breathe more, right? So what we're doing is we're trying to supplement the oxygen. But in a breathing emergency, back to originally asthma. So we're not able to exhale as much as we normally would, and causes quite a trauma to the breathing in terms of not being able to catch their breath or get enough air is what they feel like. Hyperventilating, although is more of a psychosomatic thing, it actually can be quite dangerous and quite scary. You're correct in that we need, it's funny enough, but we need CO2 to trigger our brain to breathe. So the scary part about hyperventilation, and we used to see this, I started off as a lifeguard, the kids would hyperventilate for the big lap under the pool, under the water. And what happens is you need CO2 to trigger your brain to take the next breath. And when we hyperventilate, we flush that CO2 out. And eventually, in some dire situations, it would stop us from breathing. So definitely, oxygen can help that out too. And then circulation. So all sorts of circulation problems. We talked about heart. What other kinds of circulation problems? Stroke. So basically, simply put, heart attack of the brain, right? We have a blockage or a bleed in the brain causing brain cells to die. Interesting enough, I think it's 32,000 brain cells die every second that there's no perfusion going on. And then it just ramps up from there. 1 million brain cells every minute and 120 mil every hour. So now, there's 100 billion brain cells in the brain, but still, I don't think we want to lose that many, right? And it all comes from stroke. So when we say time is muscle, time is brain. So literally, seconds count for brain. And if we can supplement with oxygen, we can try to save the secondary injury. That insult with the blockage or the bleed, right now, that piece of brain is going to be ischemic or it's going to die. But we can try to save around that area with supplemental oxygen. And that's why it's so important, right?
What about people going into shock? Can that affect breathing also?
Shock is probably, in terms of, movie shock or real medical shock, is actually can be quite deadly. Shock can kill you. And if it's due to trauma, basically shock is the body's first attempt to do its own first aid. You see in lots of movies. The blood vessels constrict, it tries to slow down its own bleeding, but eventually it will relax. And if we're having an internal or external bleed, out it comes, right? And our brain and our tissues, but mostly our brain needs two things primarily. Does anyone know what our brain literally, it needs everything, but what does it need? Two main things.
Blood and oxygen.
Blood, but it needs oxygen via the blood. And what else via the blood? Sugar. So our brains need two things, primarily, oxygen and sugar, and we talk more about that, because anytime we have a little bit of a sugar dip, what happens? We got lots of commercials out there. You go hangry, right? You don't have to be a diabetic, but we all get hangry. That's a real thing, right? Especially in the afternoon. or we get a little dozy, and that's where the word syncope comes from. We get a little faint, right? It's because oxygen's deprived. Now, the same thing with shock in terms of what happens in our body. Basically, the shock is a traveling little show. Okay, when we have an insult with a medical insult or a trauma insult, the body goes, okay, hold on, let's concentrate on our organs in our brain, right? Let's just take the easy one, some sort of bleed, right? The body concentrates on main organs and brain. So what doesn't need oxygen? What doesn't need blood flow? Yeah, so our arms, our hands, our skin. Our skin is the largest organ of our body. So we don't need blood and oxygen out in our arms and legs and skin in an emergency. So the body shunts that off. So what do you think happens to our extremities?
Cold.
Right, cold. And what do we need? Blood for our pigment? So, yeah, so when you see that person, at first they look pale and then cool because they've dropped the blood flow for pigment, they've dropped the blood flow for temperature. And finally, what happens as the body constricts its blood flow to the more important organs, guess what malfunctions now? Sweat glands. So the sweat glands go, oh, I'm out of oxygen, and they go, poof. And then we get clammy. Cool, pale, cool, clammy. So that's basically the downward spiral of shock. And what,
Does oxygen help with somebody who's in shock? They should put oxygen on them?
oxygen can actually reverse some of that. As long as we've treated the patient, oxygen and a nice warm blanket can actually reverse shock. Exactly, right? So that is the benefit of shock at work, oxygen at work. Simple to use, not scary anymore. As long as you've been trained in it, has the SOS logo on it, you can help your first aider at work not only get the oxygen, but apply the oxygen. So that's what's so beneficial. Other medical emergencies that we were touching around, another one that's normal at work, you might see bracelets, right, is the diabetic, right? So that's another one that basically if they're having a diabetic emergency, usually hypoglycemia, which is low sugar, that's the person that has a problem digesting sugar, maybe a problem with their pancreas, and again, oxygen can help that. Because right now they're not being able to convert the sugar, right? So the blood is not being able to carry around proper nutrients. So oxygen can help that person. Again, we treat that person with position, and they might need a little bit of juice or sugar if they're able to swallow to help build it up, right? We talked a little bit about anaphylaxis, which are some common, maybe medical conditions you might see at work. It's not all about life threat ABC, but some common medical conditions. Lots of times we have heart conditions. Might not be heart attack, there's another heart condition. Anyone know what that's called? People live with it. People have a spray. Angina, basically. Angina pectoris means pain in the chest. And it's a living heart condition where the heart is not blocked, so the tissue of the heart's not dying, but for some reason it's constricted or blocked for a moment. So all of the same pain and the sweat and the sick, you feel like you're having a heart attack. But they can have a little spray called nitro under the tongue, and it helps relax the vessels and helps continue the blood flow. Guess what will help that patient? Oxygen. Okay, person's been deprived of oxygen at their actual heart muscle for minutes maybe. So yeah, oxygen is a simple remedy for a lot of these everyday medical conditions and some trauma that could happen at work. Okay, any other questions on that kind of stuff, ABCs?
But, can you get in trouble for doing first aid if you don't have first aid knowledge, or, you know, if you put some oxygen or first aid stuff on people?
Well, so your company thought well enough to stock your first aid room. You'll have some level 1 first aid attendants, it's our legislation, but also you're all now basically trained helpers. So we can actually access this equipment and get it for our first aider, and you can use it. Because in terms of, unless you're employed to do so, like I'm a paramedic, I'm called to do it. I can't just say, no, I'm not gonna do it, right? As a bystander or a co-worker, we're governed by a different set of legislation. You know what that's called? Good Samaritan Act, right? Basically stipulates that as long as you do everything within your training, your purview, whatever you know, and you're there assisting, you can't be held legally liable for the outcome. As long as you're not explicitly employed to be the first aider that day, you're not held accountable or responsible. Now, there's some reality to it, which I always like to point out, which is ridiculous stuff, but you know, you can imagine if it's called, one thing where you might be held accountable is called gross negligence. That's meaning that you do something so crazy out of what a normal non-first aid person might do. You know, the old saw it on TV, right? You take your pen out and you take it apart, and you stick it in for the tracheotomy, right? It's a little outside everyone's scope, right? So that's called gross negligence. And then the other one, weird enough, is a view to gain. So it's like, give me some money and I'll help you, right? Those take you out of Good Samaritan Act, but as you can tell, especially in BC, it's all Good Samaritan Act. You're either employed to be rendering first aid or you're helping out as a Good Samaritan, and that protects us. So it's a good thing to know. It's also a good thing to know where you're traveling. Everyone hears nightmares and horror stories where you travel. Lots of states have Good Samaritan, so always know where you're traveling. All of Canada has Good Samaritan. Actually, Quebec steps it up and says you have to stop at accidents, or else you could be held liable. So, but all the provinces in Canada have Good Samaritans, so that's good to know. So let's just take a look back to A. Simply put, because it's a very simple fix, A. Any idea what you would do for a foreign body? That's the person, it's getting to be Christmas time, we're all having our Christmas cheer and our Christmas canopies. Oh my God, I just impressed myself. And goodies and telling jokes, and we start coughing. Okay, what can we do for that? Heimlich, okay? Heimlich maneuver.
Try to get them to keep coughing.
Yeah, or abdominal thrusts, or the number one thing, and what they always say on dispatch, if you ever call 911, they'll say, don't hit them on the back if they're coughing. Coughing's good. Coughing is the body's way to collapse that diaphragm up there to produce a cough. If we can't get air on our larynx, we can't form speech, and we can't create a cough. So, but if the person's coughing, and if they're trying to get some words out, that's a good thing. So we just basically stand by, hey, Bob, and we encourage him to cough. Keep coughing, Bob. What happens to that person generally, especially at the get-together, at the party? Where do they go? They go to the bathroom. Years ago, they used to call these cafe coronaries. The waitress would go in, check the bathroom, people on the floor. So we always are embarrassed, we go away. This is when you get to be really obnoxious, and it's a safe thing. Be there, try to be loud, try to show people that you're having a problem. Don't leave. Because it can be as simple as encourage you to cough, sit down, lean over, get some gravity involved, and try to produce that cough. Or at this point now, it might be where you have to actually interject, right? And then help them and tell them, I'm going to help you. I'm going to do some abdominal thrusts, or I'm going to smack you on the back. It's quite a violent thing, and it should. Has anyone done abdominal thrusts before on a real person? I have. I've asked other classes. Generally speaking, it happens within the first couple of thrusts. If it lasts longer than that, they're going to go down unconscious. But mostly, I've always heard, within 3 or 4 of these things, real hard ones, it'll come out. It's called pop or drop, so it either comes out or they go unconscious, and it could come out as a thing or it could come out as vomit. But let's maybe take a look at doing that. And to each other, maybe. Just basically what you're going to do for the abdominal thrust position. You're going to take your fist and you're going to put it just above their belly button, and you're going to clasp your other hand around it. So just aim it on yourself, then we'll stand up and we'll play with it. And at this point, what you're going to do is, it's called a J thrust. You're going to pull in and up. Pull in and up, hard individual thrust. So much so that you guys are going to try to lift me off the ground. That's how hard you do it, right? And they're one at a time, and they're quite jerky, like this. Real hard. You're going to do 5 of those. If that doesn't work, then you're going to come around to the side, hold them, bend them over a little bit, and between the shoulder blades, 5 back blows. Keep cough, keep cough, keep cough, come around, and return to 5 and 5. You basically alternate 5 and 5 until it either pops or they drop. And if they drop, you basically put them on the ground. And what do you think you do now? Besides scream, chest compression. So basically it looks just like CPR. The idea is you're still trying to force it out. Can we all just maybe just stand, if you would? Just grab your partner. Just look side by side. So basically hips, hands around, keep low to the belly button, because if you're too high, just think of this, there's no wave. You want that pressure wave. Down here, and then up and in, don't really do it. And if that didn't work, you'd slide around beside them, and then 5 on the back, real hard. And then back and forth, back and forth. Okay.
Quick question.
Yes.
That Ozzy has brought up is, what if you're alone? What if you're
Good
alone?
question.
Yeah.
Good question. What if you're alone? What do you think?
I've had to do it to myself.
Do it to yourself,
Yeah.
for sure.
Yeah.
Now, it's going to hurt. This is a painful thing, right? But what's the alternative? So yeah, you could literally abdominal thrust yourself. Okay. The other thing is you take the table edge, you get down on it, and you actually throw your abdomen into the table edge as hard as you can. Or you take a chair, you reverse it, and you pull onto a table or onto a chair back as hard as you can. Right? But you understand the alternative. The other one you can do, but probably doesn't work as well, is you make a platform and you run into a wall. Just make sure you turn your head at the last second. Okay? But I would rather do this one. But that's a good point, because that's what happens a lot, right? I know I'm choking, but I don't think they know I'm choking unless you can do that, right? So that's just an interesting part to that. So that person clears. It could be three thrusts, it could be 10 thrusts. What do we do now?
Prepare for shock.
Yeah, sit them down. What haven't they been doing for the last minute? Breathing very well, if at all. Oxygen supplemental will help them. But treat for shock or prepare. But what else? Say me and the young lad back there was doing abdominal thrusts on you. What are you worried about?
Bruising.
Yeah. If this lasted more than 1 or 2 or 3, if this lasted a minute worth of thrusting and back, I would make sure 911 was still coming. Because there's a good chance we popped a rib or we did something, right? And it would happen. It definitely would happen. Especially, when you're amped up, you're pretty strong, right? You're pretty strong.
It goes the other way. What happens if you do the thrust and they start breathing, nothing comes out? Can that happen?
It definitely can happen. So if all of a sudden the person starts to breathe, but there's no evidence of the blockage, there's a pretty good likelihood, it's thin, that it would come out my back, go down the right tube, but the right branch, it actually could go down into one of the lung branches, the bronchiole. So you still would have to go get checked. This is when you would still follow up, because there's something in, but one lung can work, right? One lung's working at least. That's why we don't do a lot of pushing in when we see it. We only go get it if we see it. right? We don't blind sweep anymore. Just we help come out if we can see it. And then again, like I said, supplemental oxygen. So this is all, you don't have these at home, but if this happens at work, this is what you can do in the lunchroom. Go get this, sit them down, get them to breathe, get them calm down, put some oxygen on them, right? And if this took much longer than a couple of thrusts, keep coming with the 911. They need to be checked out. So breathing is obvious. Breathing emergencies. This again is an inhalator. So it works with the patient breathing or inhaling, okay? The other piece to this is a pocket mask. Anyone seen these before? You have? Okay, these are basically a device, a protective device where you can, back in the day, lifeguard, we used to do mouth to mouth all the time, right? But now we have these little things called the pocket mask. They have a one-way valve so that if something goes wrong, it gets blocked and it doesn't go back into you like it used to in the old days with mouth to mouth. The good thing about this is you will, and we'll show a little bit later, you put this on the patient. So we'll do this again later. We'll put Bob up here and we'll take a look at CPR. The interesting piece of this that people don't maybe realize is if you had to use it as a mouth to mouth, you could take this mask off and there's an oxygen port on this mask and you could put this oxygen unit together with the mask. And now I am blowing in 100% oxygen to someone who's not breathing. It's a very good piece to this angle. This basically supplements you with this kind of mask, about 60 to 70% oxygen. The fraction of inspired air, so how much oxygen in the air you breathe right now? Anyone know? There's about 20% oxygen in the air we're breathing right now. This makes it about 60. This makes it up to almost 100. So this is what you would blow into someone that isn't breathing. And who doesn't breathe normally at work, what would that person be getting as well? That would be CPR, right? In first aid now, we don't really teach checking pulses in most general first aid. If the person's not breathing, we go right to chest compressions. And chest compressions is basically stimulating the heart. This is stimulating breaths. And with electricity and timing, if we're there quick, we have a good chance at actually starting someone's heart up again. Okay? So pocket mask, very good. If you didn't have this handy, I have, and I've seen, I advocate, just a piece of plastic, poke a hole through it and put it over the face and away you go. Pinch the nose and blow. It's just a way to make you brave. Make you brave, because some of us might be germaphobes. And so it just makes you more brave, right? But this is what we all have on car, and we have a big machine called the BVM, which is how we do it, but we don't need to worry about that. And in reality, when you're doing something with somebody, it's always a good idea to put these on the ground, because what does Murphy say? Now you have a head injury. Okay, so now we're going to take a look at another device, A.E.D. Stands for?
Automated external defibrillator.
Nice work. Okay, this basically is just like the one on TV, that by the bedside in the hospital room on that scene with the low squiggly line going on, except this one does it all in here. It's automated. So those machines, they can turn any down and do whatever they want with it. This one, you would open it up. I won't turn it on just yet. You would put on these pads and you would hit the button. These pads now will read what's going on under the heart. And it literally goes like this. So left side, right side, left side. And this one, the Zoll, has a cool target for your hands, so you shouldn't be able to miss that. That's where you put your hands and you push. And now it's as simple as push hard, push fast. On an adult, I'm pushing down at least 2 inches. Me, I'd ask you to please push down 3 or 4, but mostly push down 2, okay? And go fast. You're doing almost 1 a second, right? 1 a second. So you can see that in team CPR, you wouldn't want to do it much more than 2 minutes apiece. Switch out, the next person does it. Do it again, do it again. So this A.E.D. replaces hopefully will shock the heart back into being. In terms of any cardiac arrest, what's happened is because of an arrhythmia, usually, which is all electricity, it goes into a motion where it can't pump, it can't beat, but there's still lots of electricity in the heart, and it looks like this. There's two main rhythms that this looks for. The sinus rhythm is what we all have right now. It won't shock this one. And believe it or not, this one, beep, what's that called?
Flatline.
Flatline, right on. Asystole, it doesn't shock that one either, the A.E.D. You'd have to tell it on TV, they'd have to do it on purpose because there's no electricity for us or it to hit. The one it hits is what's called VTAC, that's when the heart's just pounding away, but it's going so fast that the ventricle is moving so fast that it's not pumping. So there's no heartbeat. You wouldn't be able to feel it. Clinically, they're dead. The other one is the bowl of jelly. That's AFib. Or sorry, VFib. It's going so erratic. Again, there's no heartbeat. It's going so erratic, there's no heartbeat. So there's no pulse. So there's no blood traveling to the organs and brain. So what this does, anyone knows what the A.E.D. actually does? What does it do? It's kind of a counterintuitive. Does it start your heart or stop your heart?
Stops her.
Yeah. It actually, anyone back in the day remember what you used to do with your computer just before you threw it out the window? What did you do? Control, Alt, delete. That's what this does, in essence. Control, Alt, delete. It reboots your heart. So everything, we all have this sinus rhythm, that's our normal rhythm. It actually stops the heart for a little bit to try to re-kick it into a sinus rhythm, or a rhythm that has a heartbeat. So that's what this does, right? And it does it easier if it has a course rhythm. So the quicker we can get to him, the better. So what happens is we're going to push down and compress his heart. And we're compressing his heart between his sternum and his spine. And the quicker we can get on and do this, hopefully we can change that rhythm and give it some more juice, I like to call it. Give it some more electricity. So as soon as we're on the chest doing compressions and get this put on and get the machine to read it, we might have a rhythm where it can actually shock them. Hands off, it shocks, and away we go. Every 2 minutes, it'll take a look at that. Every 2 minutes, it'll tell you to stop. I'll take a look. It'll say, yes, we have a rhythm, stand back, I'm going to shock it. Or no, I don't have a shockable rhythm. Either take a pulse to see if they're alive now, or keep going with CPR. If you did the oxygen part, and you had it, and your first aider was going, on the mask would go, and they would blow into that person. In CPR, it's called 30 and 2, 30 compressions, 2 breaths. This is what we do normally on all the street. If you were ever to see paramedics do it, they do nonstop. So we would just keep doing compressions and put a breath in every 10. The thing about having something this intense happen at work, and first aiders know this, and be prepared that if the paramedics arrived at your scene, at where you work, and you were doing a really great job, they might ask you to keep going, right? Because we'll bring on all our equipment, we'll get all set up, and if you're doing a good job and you're not, and you're allowed to powder, I gotta go. You're allowed to step back. But if you're able to keep going, be prepared to maybe be part of the team for a little bit, which is great. That just helps us, right? It helps us. Especially with any history you have about your co-workers, or especially what happened just before they got sick. That's really important, right? But they might ask you to help out, right? Don't be offended if they say step back, right? Every crew has their own way of doing it, right? So just understand. What I also like to do, especially with these trainers or these A.E.Ds, is it really helps too, because look, there's pictures. Pictures are good, so it'll help you with pictures of where to put it as well, right? Now these get really sticky, so they really stick. Guess what you might have to do for this patient, besides
Shake your chest hair.
yeah, if they're really hairy, you might have, doesn't mean you have to manscape everything, It's just where the sticker goes. So shave here, shave here. What else? Remember, I said we talked about shock. What happens, especially with a heart attack, cardiac arrest patient? So clammy that it might look like they just got out of the shower. So you might have to towel those spots down too. So dry them, shave them, and then stickers on. Maybe on some people. Yes.
Pacemaker. Can you put one over a pacemaker?
Good point. Pacemakers. Anyone know what a pacemaker is?
It's internal to regulate the heart.
Yeah. So remember those rhythms we were talking about? This thing's reading. Someone has a bit of a bump in their rhythm that can make them a little, put them into an arrhythmia, can make them a little faint, a little sick. What a pacemaker does is it kind of helps keep that rhythm going. Right? Generally, again, it'll be over here. So in a general way, we normally put the sticker here and here. The only thing we don't want to do, depending on what you're finding or panicking, is put it over a pacemaker. If you're like about an inch away, you should be fine. But generally pacemakers are here, generally pads go here, right? If not, you can put your pads here too. Just switch it around. Because they're actually biphasic. It'll go through both of them. It just helps you to remember one way, right? There's another little device called an internal defibrillator as well. Same idea that it's inside the chest, but it goes right inside the heart as well. And it's one that actually will deliver a little shock. Not just to help keep the rhythm straight, but it'll actually deliver a little shock like that because that heartbeat has fallen right off. Now, some people have that. Now, I do like to say you want to never touch your patient once you're in the shock phase, because you can imagine this thing is putting a shock through this patient, and if I was touching this patient, there's pretty good evidence that that shock could go through me. It's also good evidence that sometimes it won't because you're part of the circuit, but that's why we always clear. 2 reasons we clear when we're in a shocking A.E.D situation, because this touching is called artifact, and that makes the heart or the rhythm in the machine look like this. It's like, whoa, 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 what was that? So it might not recognize it, or it might shock something that's not there. So we always clear, and we don't touch during shock phase or analyze phase, because it wants to take a look. I had a patient once who did have an internal defibrillator. We were called because it was malfunctioning, and it was going off every 5-10 seconds. So she was being shocked every 5-10 seconds, screaming, screaming, screaming. When we got there, I heard the first couple of screams. We went upstairs to find her. She was working out at a gym. She had stopped. So we got all her stuff done, got our monitor going. I took a pulse, and I'm taking a pulse and a BP and working on her. And all of a sudden, her face went like this. And I went, what? Before I finished the word what, it had shocked her again. Went down her arm into my arm, and my arm was like this for 20 minutes. So it does hurt. It did hurt, right?
Did you finish your workout?
I didn't have to work out that because it was like busted. It was sick, right? But it put me in my butt. But it's a good thing to know. When you're dealing with this kind of thing, you want to stay away. Another thing I like to do with A.E.Ds here, and hopefully make it work, is just so you know that this thing talks to you. Automated external defibrillator. It all different kinds of makes. It's all the same principle. Could be a male voice or a female voice. You never know.
Unit OK. Stay calm. Check responsiveness. Call for help. Attach defib pads to patient's bare chest.
So it'll set you up. It has pictures here what to do. You've taken this out. You strip open the shirt. This thing will still remind you to keep doing this. Strip them open. Take your stickers off. Get this on. Flatten it all down. And once you're here, it'll know. Now this is a trainer. That the pads are ready.
Patient's bare chest. Don't touch patient.
Okay. Now it knows here. Now it's looking to see if there's a heartbeat or what kind of rhythm. I'm clear, you're clear. I'm clear, you're clear. We're not touching. It's looking, and it'll take a look at shock.
Shock advised. Don't touch patient. Press flashing shock button.
As soon as you see that, this is the thing you want to be careful. You hear the noise, you see the flash. If I reach over and I touch the patient, it's not good. So I can ask someone to do it, or I just make sure I do it.
Delivered. Start CPR.
And away we go again. it'll actually give a metronome, so it'll give you a good pace to go and a good rhythm to go, and away you would go. At 30 compressions, if you had it, if you were set up and helping your first aider, they would give breaths. Normally, the first aider will put you on the chest because it's easier to do it that way. Okay? It'll also, so those are a stop for 2 breaths. Also, if you weren't doing it right, this reads you.
Push harder.
So it'll know how deep you're going. It'll actually measure the resistance.
Good compression.
Thank you. Thank you very much. Okay? So there's stop for 2 breaths. The other guy goes on, and away we go again. Right? And it goes on like that. 2 minutes, it'll tell you to stop, clear. I'm going to now reanalyze the heart rhythm to see if it's a sinus or if it's working, or if I get another rhythm to shock. Okay? And that's an AED. It talks to you, it tells you what to do, there's pictures. Guess where you can find these now?
In your first aid room.
In your first aid room. Make sure you know what color it is, where it is, what's that, where it's located, where it's hung up. Bring it always with the this and it, oxygen, your AED, and your first aid kit, right? But guess where else you'd see these?
Shopping malls,
Shopping malls, grocery stores, swimming pools, ice rinks, and those are called PADs, public access device, defibrillators. That means you could go smash it, bring it to the person that's in trouble and help use it, and you're still a good Samaritan. And pictures and voices, and basically takes you right through it. And your voice. This is where you don't get timid. This is where you yell, help! Call 911, right? Think about 911 nowadays. What can you do? You can call right here, put it on speaker, and they will talk you through it too. You're never going to be alone. They will talk you through anything you have. Any medical call you have at work, they'll talk you through it until your first aider can get there. Right? Any questions about this?
Unit okay.
I'm going to turn you off.
Can you reuse the pads or do you have to throw them out?
Good question. Good fiscal responsibility. It's a one-time use, right? Good point. So one-time use. Batteries last a while, but pads one-time use because now you get all the hairs on them.
Body sweat.
Body sweat and hairs. But good question. So masks, oxygen masks, one-time use, right? Pocket masks, depends on you. You might want to wash it out, but one-time use. All of this, all first aid stuff is basically one-time use. And there you go. Now, if you ever had that situation where the patient awoke from your CPR, what do you think you do now?
Keep them lying down.
Keep them lying down. Keep them comfortable. Keep them calm, right?
Oxygen on them?
Waiting for that. This was a ventilator because I'm venting you. Now you turn it back into an inhalator. So now put oxygen on them. And what else do you put on them? I actually wrote a paper on this. It's the goodness of a blanket, a warm blanket. Because remember, it's helping reverse shock. If I can keep the person, I'm not heating them up, but if I can keep their temperature, then I can, the heart works easier. What happens when we get cold? What does our body force us to do?
Work harder.
And shiver, right? And by shivering, now I've made the heart, which just had an attack, work harder, right? So I want to not shiver. I want to maintain body temperature. Homeostasis, if you want. I want to bring up the temperature to normal. I want to put supplemental oxygen on. The only thing I might add, depending on them, is maybe put a pillow under their head. All about it. Or if they're sick and vomiting, just then park them on their side. It's called recovery position, or three-quarter prone. Or remember in high school or college, you did that to your friend. Put them on their side, right? Put them on their side. You just want nastiness to go away and not back down. Now you have another problem. So that is A, that was B, C with a heart. What other kinds of things do we have in terms of C, circulation? Now, some of your companies, if it's a heavier industry, this might be a little more obvious than your nasty paper cuts, which are even worse.
Blunt force trauma.
Yeah, some sort of blunt force trauma, some sort of trauma that has now lacerated you. Now you're bleeding heavily. Now, we all have bleeds, and bleeds can be done by tons of dressings and bandages and dressings, and that's awesome. But there are some bleeds out there that are so dire that if I don't stop them, it's why it's ABC. Another way I like to look at it, and it's kind of rude, ABC is how is my coworker going to die in the next 4 to 6 minutes? And that's why ABCs are so important. And how do we die in 4 to 6 minutes? We either stop breathing, heart stops, or we bleed out. Or we bleed in, depending on blunt force trauma or penetrating or exsanguinating trauma. Okay? So, some simple things we can do. Level 1 kits have come a long way from just band-aids and stuff. Level 1 kits now have what are called, we call them zap straps on ambulance, or they're also called trauma straps. Nice hard elastic, where, may I borrow someone?
Yep.
Can you want to come up here? Actually, I'll come over there. Just want to see. Give me your sleeve. Now these work better on obviously legs, it's a little bigger, but say she had a major bleed coming here, a quick bandage, you just want to put your hand on that.
Yep.
She probably wouldn't want to help me because she's probably quite in pain. But all you would do, put this on, and as hard as I can zap it, and there's the elastic bandage. It's great for a bleed. And then if afterwards, on the ground she'd go, and there's enough elevation. But this is as hard as I can pull it. Because in town, everything we're here, we're probably 10 minutes away from a paramedic. They're probably 5-10 minutes away from a hospital. That's how quick it would be. Okay? These are great. We use these all the time for bleeding or zapping legs together if we've broken other things like hips and pelvises and stuff. The other device, which is quite fascinating, because when we first started off, we heard the term tourniquet, right? And we were all a little nervous about tourniquets. We were told that they're very dangerous, and 45 minutes on, 5 minutes off, and be careful because they could lose the limb, and all sorts of different things, right? Nowadays, through science and data, and where do you think we get the science and data for most trauma in paramedicine and first aid?
Hospital?
Nope.
Military?
Military, wars. So all the wars that are happening, that's where we find all sorts of new stuff we do for trauma, especially on ambulance. And one of the things is tourniquets. So the battle happens, the soldier gets hurt, the limb gets hurt, they put one of these on, take them back to the helicopter, fly them back to camp, fly them to hospital. 6 hours later, these will be on, and they're saving lives and saving limbs. So tourniquets have become a go-to device now, even in basically simple level 1 kits. Tourniquets and zap straps are now in level 1 kits. And it's simply put, you have a coworker that is bleeding to death, right? This is nothing that can be held by direct pressure. If it's held by direct pressure, great, use your zap strap. But if it's bleeding through your dressing and bleeding through your fingers, go right to a tourniquet. And you can do that quickly, because probably what are they doing?
Not moving.
Or they're screaming their head off. If they're screaming their head off, what do you know?
They're in pain.
And they're breathing. They have A, they have B, go to the bleed, right? If they were unconscious and bleeding, I might have to take a second if I'm by myself to make sure they're breathing. If not, I could just go right to the bleed. And a tourniquet, again, is a simple device, and it's a painful device. You can understand the idea behind a tourniquet is to stop the blood flow. Not to reduce it, but to stop it, because it is bleeding so much that it's blowing through all of my dressings and bandages that I did first, and I need to stop it. Okay? Can I have you come up front, sir? So again, major bleed coming from down here. Generally more of a, maybe something in the parking lot at your job, a vehicle accident, or heavier industry, whatever you're talking about. He's done some sort of major laceration here where I can't put direct pressure on it enough. Simply, I would slip this up to the artery, so the main artery in the leg up here, and the main one in the arm is the brachial up here. I would tighten this down as tight as I can, and I just Velcro it back on itself. It's all Velcro. There's this thing called a windlass. There's a hard plastic piece. I just turn this, and in reality, I'd probably turn it at least 3 or 4 times, but here just once, because I'm trying to stop the blood flow. So you can already see how tight that is.
Yeah.
If I did that another 2 or 3 times, it would hurt, but I'd stop the blood flow. I then put it in there where it traps. Now it won't spin off. I then run this through so it doesn't get caught. And I put this piece over top to trap it all. And then I would write the time here that I put on the tourniquet. So in surgery, they know exactly how long this has been on. You can see his veins popping out here. I could rent you to some paramedic students who could practice their IVs.
No, thank you.
That'd be good. So again, once a tourniquet is on, the rule, don't take it off, right? Now, here's the other piece that people forget. I've done this is great, but what do I have here?
Open wound?
Yeah, so now I get to treat it. Cover it and put a zap on it. So I need to treat those open wounds. Am I worried about infection with a major bleed? No, because it's all coming out this way, right? It's all the minor bleeds that we treat that we need to clean first and then treat, right? But major bleeds, I'm not too worried. Thank you. So that's ABC, or D, ABCD, deadly bleed. You can play with it. You want E? ABCDE?
Let's do it.
Escaping air. Where's that one?
A hole in the chest.
Nice. So again, the typical gunshot happens every day, in your place of work. No, but any kind of penetrating injury for the chest, or even thorax, but the chest, right? We have escaping air. So this is another problem where we're going to have escaping air. So the chest is a closed unit. The lungs work in its own little sac. But if we bring outside air into it, eventually this lung will what? Collapse. Now what happens in this space? And then what's going to happen to this other lung?
It starts getting compressed.
Eventually, you'll even see the trachea move over. You'll see the heart get compressed. But you could see this lung now come under this intense internal pressure. And then what might happen to this lung?
It deflates.
Yeah, it's called a tension pneumothorax. So you've started with an open pneumothorax, and the general classic look is some sort of penetrating hole with blood-stained bubbles, right? So that's a good way to identify an open pneumothorax, blood-stained bubbles. And then eventually a tension if this lung goes too. What's a quick, easy fix for an open pneumothorax?
Cover the hole.
Done. If they're conscious, get them to put their hand on it, right? Eventually, you'd want to, and this is a great piece, the inside of this is sterile. You can even put that on the wound in the meantime, as you're taking care of everything else. This is a simple fix, right? And right now, what they're teaching is actually the simple fix is this. Because we're so short term, paramedics should be there anytime. They'll take care of it. We have special seals that we can stick on them that have a valve, right? So this is a simple piece. What might happen though, if we have this open pneumothorax, we have this now hole in the lung and a hole in our pleural sac, or pleural cavity here. Now there's air coming into the chest. What do you do if all of a sudden, you've seen this on the movies, the breathing starts to get tense and the neck veins pop out? What's going on? Why?
Because air's in the wrong place.
Right? Now what can we do?
Give them oxygen.
Oxygen, right? They're suffocating. So oxygen. And what's a real simple fix, especially at home, if you've ever used Tupperware, what do you do with Tupperware? When you put the lid on, and what do you do with it? You burp it. So literally what you can do is take this off, clean it off, put it back on. You basically let the air out of the hole and then cover it up again. Right? In the movies and in paramedicine, they put a needle in them, and it can release the air out of that way. But simply put, in general first aid, cover it with your hand, your glove, a piece of plastic, put the gauze on it, and then once you start having trouble breathing, let it out, cover it back up again. That's a simple fix. Oxygen, always supplemental, okay? And that person needs to be treated, right? It's all about maybe lay that person down, but what happens when you lay a person down that's having difficulty breathing?
Put more pressure.
I gotta sit up. So then they just prop them up, right? Normally semi-sit, those kinds of people, right? Excellent. How about finally maybe, so we talked about stroke, but we'll tie into it what's known as TBI, or traumatic brain injury. And traumatic brain injury starts with what? What kind?
A hit to the head.
Hit to the head. What kind of injury did they call that? We see it every day on TV, in sports.
Concussion.
Concussions. The number one obvious traumatic brain injury is concussion. It can be just a brain shake, a little rattle, a little electrical impulse, like a little fix. Generally, it goes away with time and rest, but you could have nausea, pain, headache, slurred speech even, and some short-term memory, right? A lot of times we get that patient that's, whoa, what happened? Where are my shoes? Whoa, what happened? Where are my shoes? Repetitively, all the way to the hospital, right? We have to answer that question all the way. So that person has a bit of a brain shake, right? Might not be major trauma, might not be, we don't have to run and get a collar on them and put them on a board. It could be, they smashed into the cupboard, or they've tripped in the sidewalk and hit the side of their head and have a little bit of a lights out and they come back. Could just be a concussion, which is a misnomer because it's not just a concussion. This person will always need to go look at. What kind of patients that fall that we should always make sure we get a look at, especially in the workplace? Elderly, right? Elderly. What sometimes do our elderly patients, what kind of medicines do they have? Blood thinners, right? Anticoagulants. So things to stop clotting. So if they have drugs that reduce clotting factors and they have a tiny, what is a concussion? It's a bruise. What is a bruise? What's technically a bruise? Internal bleeding. So now they got a little bleed going on in the brain. A tiny one, it's a bruise, but it's now anticoagulated. So generally in paramedicine, what you might find is if someone that you know is normally quite with it and now all of a sudden they're altered and you ask them questions and they fell 2 days ago, that's a typical classic subdural bleed. That's a little bleed that drips, and all of a sudden now they're altered because they have pressure in the brain. So that's from a simple fall. And that could have been a concussion at first. That's why in most major sports and pro sports now, you see them all having the concussion protocol. They all get a baseline set of neurological exam, and what happens, they compare it to their baseline. And that's why they're either taken out of the game or off the field for a bit, because as we found out, concussions are accumulative. They're quite deadly in terms of behavioral, psychological, suicide, like all sorts of nasty things with just concussions. So they take care of those quite well. So at work, if someone is altered, it could be what? What does the brain need again? Oxygen and sugar. So these are great follow-up questions. And altered could be a fall, right? Could be a previous fall, right? Oxygen will help. Position will help. 911. Okay. Anything else? Any other what ifs or conditions? What ifs? What about?
What about electrocution?
Electrocution. Ouch. Where do you work?
I don't.
You don't work? I don't anymore.
But it's so easy to get electrocuted. You can get electrocuted in the lunchroom, like playing around with putting the toaster cord in and then.
Very good. Very good.
So, yeah.
Trying to get that
Trying to
last
fix
piece of
something.
toast out. Okay, electrocution, tough, very scary. A, for the patient, but B, for you. Part of first aid always, it's quite funny because we always say this is paramedicine, but who's the number one priority in a paramedic or first aid call?
You as a rescuer.
You are. And if you had a partner,
You.
they're second. They would think they're first, but they're second, and then the patient is. So it's all about safety first, right? It's all about safety. So say you came into this room and they had wires everywhere. It's like something was shorting out. Like technically, you wouldn't even go into that scene until someone with some knowledge was able to de-electrify the environment, right? So in terms of electrocution, you got to make sure that it's locked out, right? The patient, if it's a high enough voltage, will be stuck to it for a moment, right? So you touch that patient, now you're continuing the circuit, now you're part of the accident, and you're going to get electrocuted. A lot of times, it'll be a contact and a ground. That literally means it goes to ground. So I've seen it where they've touched something, and it's gone through them and out through their foot. So when I've come upon those kinds of patients that are truly electrocuted and not shocked, but electrocuted, you'll see an entry burn and an exit burn. And quite frankly, those are my least worries, because they're usually a black charred, like a burn, but there's no bleeding. It's cauterized, it's good to go. But what's happened is, what do you think is the main problem? Yeah, it goes through me. So I've hit might have done some brain, because this is where we live in the medulla. There's our respiratory and our heart center. But it could, what is the heart again? We just talked about it. It's a biomechanical electrical pump. So the shock comes through, fries out that rhythm. So now I've got some sort of arrhythmia going on. It maybe kicks in my breathing, and then it leaves. So now I might have a heart arrhythmia that isn't pumping blood, that could benefit from all this, right? And also a breathing ceases, which could easily benefit from pushing air into them. But I have to make sure that electricity is off. The other part, depending on the voltage, this is kind of freaky. It's enough voltage to contract the muscles to actually break bone. So now I have a broken person, especially if they're up on a ladder and they're doing something and they fall. So now I have broken bones, heart, and probably a head injury because they fell. So electrocutions are a tough, tough accident. And for us, it's all about our own safety first, fortunately and unfortunately, and then it's going to make sure the scene is safe, because now all of that stuff's unsafe, and then it's get to the patient. Follow directions from your first aiders and help with any pieces of equipment that they'll need. You might be, simply put, and this is just as important, you might be at their head holding it with your elbows on the ground. What are you now? You are, in terms of first aid,
Support.
you're a splint. You're a splint. Because what is the ground, technically?
Backboard.
It's a backboard. It's a splint. So now I'm splinting that head, that neck, that might have had that big fall to the ground, and that's my job. And it's a great job, because if that patient starts to move, there may be damage to them. So that could be part of your job too, is just holding parts, elevating parts, holding pressure, holding stabilization. And that's all fine. And all of that comes with also gloves. I mean, unless they're open and vomited or lots of blood everywhere, gloves are important, but you might not need gloves at that point. But every first aid kit has lots of gloves. So lots of gloves, put them on, and away you go. A good question, right? Good question. Any other condition or injury that you thought about or happened or you've seen happened? So, what we'll do is just finalize here, recap, SOS. So they supplied the oxygen for your first aid room. We have A.E.Ds. We have all types of levels of types of oxygen. It's all the same. It's all an inhalator unit. We have first aid kits to help all your needs, level 1, 2, or 3. And this cool little apparatus over here, which is like basically a mobile dressing station. And so the ERT is just to give you some bravery, some quick knowledge, and also a real quick show of how you use your oxygen, how you can be a benefit to your first aider, and your coworkers if something happens.
Can we see it one more time?
The oxygen unit, in terms of this one, and this one, Bob, and even this one. This is called the soft pack. You rip this open, and it lies on the ground, and it's completely the same idea. Turn on, oxygen goes. So all of these are the same unit, and as simply as it turn the lever on, turn the lever off. And it bleeds out the system. Now there's no pressure in the system anymore. So these are all your units that you'll see, one of these kind. Make sure you know what yours looks like. Make sure you know where yours is, where your A.E.D is, and where your first aid kit. Because these are the things that your first aider will actually go get, right, as part of the call. The other piece that I can't say enough is time is brain, time is muscle, is have someone relay, we're over here out at the door, right? Again, recapping on these units, with this simple lever here, these are the only units that are on an on-off unit like this. It's basically automated. You don't need a key, you don't need a wrench, you don't need to fumble and find things. It's literally an on and off wrench like that, and it's gone. And then if you ever use your whole tank, obviously your tech would come and refill your tank, actually exchange your tank, give you new masks, so it's all taken care of by your SOS. Okay, thank you very much, everyone. My name is Brad Fraser, and I invite you to come up here and take a look at the units. Just take a look at the units, turn them on and off, that'll be wonderful.